What's up, Des Moines? Doc Ladd here with the Fit Moines podcast. Today, I'm joined by Rich Green, CEO of DMOS Orthopaedic Centers, one of the leading orthopedic organizations in the Midwest. Rich brings more than 20 years of healthcare experience with a background spanning physical therapy, operations, leadership, and healthcare innovation. Since stepping into the CEO role, he's helped lead DMOS through a rapidly changing healthcare landscape while focusing on patient experience, organizational culture, and long-term growth. Today, we're diving into the business of healthcare, the future of orthopedic care, and what it actually takes to run a modern healthcare organization. Rich, thank you so much for being here.
You bet. Thanks for having me.
Absolutely. I'm super excited for this one. It's not every day we get to talk to the CEO of a practice. And so I'm excited for that, but also just with your background as a physical therapist, kind of unique. So
it is unique.
Yeah. Well, let's talk about that quick. How'd you get from physical therapy to running
Here?
Yeah, to running. Now you're in charge of the surgeon. It's kind of usually it's the other way around, right?
Well, yeah, something like that. Yeah, I think, as a physical therapist for 25 years, I've worked with both of the major health systems in town. I worked here for a number of years as a physical therapist as well. And that really gives you the foundation of what orthopedic surgeons go through, therapists, of that patient interaction. We call it being on the other side of the door. I've been in the room, and when we make decisions based on that one-on-one relationship between the physician and the patient, things really go well. DMOS decided in 2015 they wanted to have their own physical therapy clinic, so they asked if I would come in and stand it up from the ground up, which I did. We opened 3 clinics up and got them going pretty quickly. And it did well. The administrator here at the time stepped down, and they asked me if I would fill the interim role, which I did, and then did that for a couple years. A few years later, went and got the CEO role, and I've been doing that ever since. It's been a wonderful journey, and it really has been. Brian, when we see patients, it's one at a time.
Sure.
And I'm able to look at it from taking care of 10,000 patients a month type of thing.
Yeah.
Because you're really looking at their experience when they come through your organization.
Sure. Yeah, that's amazing. Yeah.
Yeah,
Such a cool path. So healthcare is changing fast and private orthopedic groups are under pressure from every direction. What does the landscape actually look like today?
That's a loaded question. I think and we talked off camera just about how running a private physical therapy practice is not that much different. You really take all the complexities out and you spin it down to what's important now. Well, revenue over expenses. And any of us in healthcare knows that our revenues are shrinking. And most of the time, we have absolutely no control over that. And in my opinion, there's too many hands in the cookie jar. There are too many people that don't provide care that are siphoning money off of the system. And that's less and less for the people that are treating the patients, and not only treating the patients, but taking the most risk. When you see a patient, one of our surgeons see a patient, there's a risk of that interaction. The insurance companies don't have any risk. They just take the claim, run it through, figure out how to pay their admin overhead and move on type of thing. That's a big one on the reimbursement side. On the expense side, it's like any business. Your people are costing more each year because of what's happening in our economy, and that's fine. Our people need to take care of themselves. We need to pay them, and we do pay them pretty well. Supply chain costs, things like that just continue to mount. So it's this ever-growing balance of revenue coming in with expenses that raise. Sure. You can't cut your way to prosperity, so we've got to find different ways to improve on the revenue side while really keeping our compass on the patient experience. And that's the primary goal behind having all of our ancillaries in place, like our MRI and our PT and our surgery centers, and those is that the surgeons can provide end-to-end care. And within each of those stops along the way, there's opportunities to provide savings. And that's what we do with our direct-to-employer contracting strategy and some things like that.
Yeah. It's funny you mentioned not funny, I guess. Not really, but the insurance. Yeah, exactly. That's a better word for it. Just this morning, literally this morning, I've got 2 different emails about 2 different insurance groups. One's cutting their reimbursement for physical therapy. The other is changing their prior auth. So now instead of 24 visits, we only get 6. And so just like you said, it affects everyone, right? It's all down the chain, and you kind of have to get creative with how you go about managing
to survive, right?
Yeah.
And the prior auth thing, you're going to get me rolling here pretty quick. The prior auth thing, the number's either 92 or 98, and I think it's 98% of all prior auths are approved in the end. So why the hell are we messing around with it from the beginning? You're talking about 2%. The insurers will say, well, it's to make sure that we don't have fraud and abuse. It's like, well, you're killing us, though, because as an owner, as us having an organization, it costs us more pennies on the dollar to capture the dollar. That's the other thing that's unique about healthcare is you walk into Hy-Vee and you buy an apple and you give them $1 and you walk out and it's done. Here, you provide a service and then you put a claim into the insurance company who then does all their stuff back and forth, and then you get paid. The same thing you go through, but it costs you dollars to get paid. Yeah, they're going to pay you $10 or whatever, but you're only going to probably take home 5 of that.
Yeah.
Because it costs you 50% or more to capture it.
Right. I've always said too, with the prior auths, take an ACL, for example. There's got to be someone at every insurance company that has the data on how much or how many visits it's going to take for your average ACL to fully recover. And so why do I get 20 visits and then I've got to request more and I get 4 and then I get 4 and then I get 4? We got to do that for a year until it resets and then we get to play this game all over again. There's got to be the data out there that they know exactly how many visits it's going to take on average. So like you said, why can't we just get those visits to start with and let's go from there?
You're 100% correct. There's data there. That's what the actuaries look at, and they work back from that to make sure they still have a margin to take care of or to be able to pay for the higher cost claims.
Sure.
What we've really done is looked at it a little bit differently. Trying to fight the insurance companies, you're not going to win. Their lobbies are way too large. They're way too ingrained. But if you go out and take your pricing like we do with many of we've got 46 bundle prices right now, meaning if you want to come in and have a total knee replacement with us at our surgery center, it's like $560. That's for the surgery, for the physician, for the surgery center, for anesthesia. You do the same thing at a hospital, it's usually about a $10,000 increase in that. So I go to a company and say, here's our bundle payment, here's our direct payment. And they like that because they can save money and budget for it. Then it becomes an invoice system. Yeah. So I don't have to go chase the claim. I've got my dollar there. And I know the next year we set a inflation kicker in. So the next year gets a little bit higher and the next year gets a little bit higher, and you're keeping up with inflation.
Sure.
That's the way to beat it, is to go right to the employers and have them look at rebuilding their benefit plans to include.
Sure.
I want to send my guys over to Brian and Kaizen because he does a great job. We know the price and we know what he's going to do for visits. It's where we're going. If you're behind that curve, you're probably not going to catch up.
Sure. I just had Dr. Vanderveer from Exemplar Care.
Yeah, John's a great guy.
Very similar model, it sounds like, with direct primary care, where it's just a flat fee. We could come in as many times as you need. Let's actually take care of the patient and get you feeling better.
And, going back to 1992 when I came out of PT school, I would have said you're crazy if you're ever going to be able to put a model like that in place. Yeah. And now it works. We redesigned our benefit plan 4 years ago for our employees and put direct primary care DPC at the top with Dr. Vanderveer and his group. And it's been great. Had about 20% of our folks went the first year, and then they built up to, I think we had about 42% go last year. And I think part of it was people, when you tell employees you can go here for free, we're prepaying it. They don't believe that until they do it.
Right.
And they spend time with them. Yeah. And then they don't pay anything. And it really is a wonderful model. It's catching on across the country, and it's something that we've invested in, and I hope other people do as well.
Yeah, we have such like an archaic system where people, I think, are hesitant because they expect a bill 3 months later, and no one wants this surprise bill for hundreds of dollars that they can't pay,
Yeah. What's the catch, right?
Yeah, exactly. And that's not how healthcare should be, right? So I like your model where, like, hey, this surgery is going to cost X amount. Everything's included. You're not going to get a separate bill from anesthesia or, someone else that happened to be in the OR that day. Like, this is what it is. That just makes sense.
Yeah, it does. And like, again, when you first look at it, you're like, my goodness, is that ever going to work? But it really does. Yeah. And the employer groups that utilize this are getting a lot of traction with it. We form what's called clinically integrated networks, which is really focused on value. You have to have portions of that with patient experience and outcomes that are excellent to be able to go through this, because we assume some risk when you say this is all it's going to cost. I mean, our docs have to be good, because if they go in there, they're not very good, and then you got manipulations and things after that, that's coming out of that pile of money. So it's sort of checks and balances internal with programs like that.
Sure. Yeah. How long have you been doing that?
We've been doing bundles for about 4 years now, and they've really caught on in the last 2.
Okay.
We've done direct to employer, probably for 4 years. We're in Aplos Network, which is part of what Dr. Vanderveer's in.
Oh, sure. Yeah.
There's a network around town. We're a tier 1 provider in that network. We're on several different platforms where people can find our pricing and say, hey, I want to go there and have their surgery done. We're soon to unveil pricing structures in our urgent injury clinics and our PT clinics where people can just pay by the click.
Oh,
type
sure.
of thing, or by a package. They come into your office and say,
Yep.
hey, I want 6 visits, and you price it out and say it's X amount. It'd be like $600 or $650 or whatever. And they know
Yeah.
that's what I'm going to be charged. And you don't chase the money.
Yeah. Yep.
And we've seen our self-pay go up so much recently that we have to get into a program where we offer things for folks that are self-pay.
Sure.
A lot more than
Yeah.
we used to.
Yeah. Yeah. I had a conversation with a guy yesterday, and I asked him what his insurance was, and he said, "Oh, it doesn't matter. It's terrible anyways, and I just prefer to pay cash." And he didn't even. I don't know what his insurance was because he didn't tell me. He's like, "I don't care. I don't want to pay cash."
They call it
Yeah.
catastrophic insurance.
Yeah, it really is. Yep.
And it is because their deductible's $10,000. So you really don't have insurance. And we see folks
Right.
come in here saying, well, I have insurance. It's like, yeah, but your deductible's $8,000.
Yeah.
So we can't do anything until you meet your deductible.
Right.
And then they're like shocked. And that
Right.
was really the onus for getting into this value-based care and some of these things was we really need to bend the cost curve. Our docs are just getting so frustrated with, we need to do this rotate. You know how important it is to get a fresh rotator cuff taken care of pretty quickly. We want to do this rotator cuff repair, and the patient will say, well, I really can't afford it right now. I'll come back and see you in 8 months. Well, gosh, in between that 8-month period of time, they developed all these bad habits. That tear might have gotten bigger. The tissue's not going to be as great to repair.
Right. Right.
And you're going to get a poor outcome.
Yeah.
We had to figure out a way where we can shrink that gap so they're not having these huge deductibles.
Yeah, absolutely. What's something most people completely misunderstand about running an orthopedic group?
Misunderstand.
Yeah.
Huh, that's a great question. I've never been asked that question before. Good one. Yeah, you stumped me on that one because I don't know about misunderstanding. I think the understanding is a little bit of the perception of what we do and who we are.
Sure.
And this a little bit comes from the insurance, but sometimes patients, they say, I don't want to go to a surgeon because they do surgery all the time. We keep track of that. And we call it conversion, which is a bad word to use, but our surgery rate per patient seen is about 19%. The national average is 22%. Only 19% of the patients that walk through our doors and see our surgeons ever have surgery. That might be something I think people misunderstand a little bit when they look at DMOS. And we pride ourselves in that fact, even though we are surgeons. Hopefully that does also reflect upon the value we see in physical therapy and conservative care and things like that.
Sure.
That's really kind of a good goal to have when you're running an orthopedic group.
Yeah. I recently spoke with Dr. Jacobson at Capital. And he said the same thing, 80, I can't remember exactly, 80 to 90% of the patients he sees, he doesn't operate on. And so that was kind of what he thought was, most people misunderstand or they don't see where, a lot of times they think you're a surgeon, you're going to operate, but it's not always the case, right? There's so many other factors.
Exactly. And if the surgeon's only doing surgery 20% of the time or 21% of the time, then that other 80% of the patients, why are they starting at such a high level of care? Why don't they start with physical therapy?
Sure.
Or with an urgent injury visit to be able to get taken care of on that level. It's less expensive and it's going to be a lot more timely than waiting to see a surgeon. Yeah.
Yeah. What's that? The old stat is like 80% of people have low back pain at some point in their life, but only 20% of people get care. It's just, it's mind blowing. Yeah. How much has healthcare changed in the last 5 to 10 years from an operational standpoint?
It's ever changing. Last 5 minutes has changed. I mean, to your point, insurance companies come up with these wacky rules all the time that we need to bend on. I think the biggest push we've seen operationally in the last 18 months has been AI and where AI comes in to your operations.
I'm glad you brought that up because I was just going to bring that up too.
Yeah. And Mark Cuban just had a quote, either yesterday or today, that said, in 2 years, the groups that have divided themselves up into where AI goes and where AI doesn't go are going to survive, and the ones that ignore AI are not going to survive. And I think he has a point because that technology is so strong that you have to pay attention to it. The challenge is not jumping in with both feet.
Sure.
because it's still a little bit unknown as to what it can do. In our realm, similar to yours, AI for prior auth, AI for our phone center. We have AI right now on our X-ray with a system that when our newer PAs, our mid-levels, because doctors, surgeons, they show up to us, they can read an X-ray clearly. But our mid-levels might not have read the 10,000 X-rays that they have. So if they read an X-ray as negative, they hit a button, AI reads it and then says, oh, you might want to look at this little spot here. And it'll catch something that they wouldn't catch, which has been a great risk management tool and learning tool. Because the next time they have an X-ray, they're going to look there and go, oh, well, that was kind of like similar to the other one.
Yeah,
That's an example of how you kind of utilize AI in a way that's really a positive effect on the patient care.
Are you using it with documentation?
Yep. We're trying. It's a learning curve. Do you use it? Do you guys have it?
Yeah, we do. We've used it for probably at least a year now.
Has it made a big difference?
A huge difference. I don't think we, there's just 3 of us right now here. Usually if there's a note at the end of the day, it's mine. To be honest, my other providers, like they leave here and their notes are done, which that's unheard of. It's crazy.
It is unheard of. And we've seen it work really well in the primary care model. I've talked to primary care physicians that put this in and it saves them 5 hours a week, which is career changing for some of them.
Yeah.
We've got several of our docs that are trying out a couple of different systems where their frustration mounts, you have to call everything out. So all your special tests you have to call out and you have to do those things, but they're getting used to it.
Yep.
And it, in 5 years, everybody's going to be using it.
Yeah. I think that's a little bit of a change, I guess. I wouldn't say challenge, but I'm kind of used to it now. When we first started, I would just tell the patients like, hey, the computer's listening. I'm going to kind of talk through this.
Yeah.
Just so they know, they're like, what is this test? Like, well, this is why. But I think it actually is helpful because you have to talk through the entire exam as you go. And so I just use it as a learning tool, hey, we're doing the speeds test. This is what this test means. And this is what we're looking for. This is what you demonstrated with it. And so I could see how it could, potentially take more time. I don't really think it does as you get kind of used to it and you kind of flow through it. And I feel like patients like that because they know exactly what's going on and they're not kind of lost during this 40-minute exam,
Mm-hmm. No, it's great. You play that thing out. So ambient AI can hook up to a system that hears what you're saying. So in a physician interaction, they'll say, well, we need to order physical therapy. We need to order an MRI. Need to do a couple other things. And they walk out of the room and the order's already been sent.
Yeah.
Because the AI reads that and then it codes it at the end of there. So to your point, all you got to do is sign it.
Yep.
And that's pretty amazing.
Yep. And then, I was going to say, especially over a full day, if you're getting behind and you're rushing to the next patient, you don't have to remember what just happened in that last visit. And, you sit down at the end of the day and there's a stack of notes and you're trying to remember what's going on. Well, then you hop in it and this AI has it all kind of written out for you. You just have to proofread and make sure everything's in there that you want.
Yep.
Such a time saver.
It is a big time saver. And we're looking at employing in several places. The big scare right now, and you hear it, that article came out, it was about a month ago, and the Dow lost 1,000 points because it basically said it was the doomsday AI. There's gonna be high unemployment, everybody's gonna lose their job and things like that. And I went to a recent conference and the speaker said, you know what AI is gonna do? It's gonna take all those little mundane tasks that you don't think about during the day and take them away so you have more time to think.
Yeah. Yeah.
I thought, man, that's probably really, really accurate.
Yeah.
So your coders can be better, your billers can be better because they're not going to be tied up with all the little stuff. They're going to focus on the big stuff.
Right. Frees them up so they can actually use that brain power to do do what they're supposed to be doing. Yeah. So what keeps you up at night as a healthcare leader other than insurance?
A lot. As part of the gig, we've worked really hard here on developing and establishing a culture that it is strong and lasting. DMOS always had a culture. They just never really put it into place until when I started. That was one of the things that we really did was put that into place. And protecting that culture is really crucial for us. And in order to protect it, you have to have a lot of things that are going in the right direction. And it starts with your employees. If you don't take care of your colleagues, you're not going to go very far. So making sure that in a world that's turning over so much that when they come to work, that they're focused on what they do and they like to be here. They're part
Sure.
of something bigger than themselves. And we really try to emphasize that. But the world tugs at us and you see higher attrition rates, not necessarily turnover, but folks that just get out of the rat race altogether.
Yeah.
And that can be a scary thing when you're trying to continue to push your way forward. That's a big one. The way we're reimbursed and how much stranglehold the BUCAs, the big insurances, have on the system right now. That's a tough one. It shouldn't really keep you awake at night, but it does a little bit because you
Yeah.
just don't know where you're going to go.
Sure.
We've recently opened up an Urbandale location, which was about a year and a half, 2 years ago. We've got a Norwalk building that's going to open in August of
Yeah.
this year. Those are risks. The doctors invest quite a bit to bring a clinic to the community. And you, at the end of the day, hope isn't a strategy, but you really do hope that it turns out
Yeah.
to be a good thing.
Right.
So yeah, some of those things are kind of interesting to deal with from this seat.
Yeah. How many employees do you have at DMOS?
We have 350 now, something in that ballpark. When I
Yeah.
started, we had 280, and we've
Okay.
grown
Yeah.
with that.
Yeah. How do you manage? You talked a little bit about it, but the culture in a business is super important. I mean, here we've got 6 people. And so, it's pretty tight knit and making
Yeah.
sure we have that culture and we're growing. But how do you do that across 350 people and ensuring you've got every, the right people in the right seats and that they're on board and we're all rowing in the right direction?
It really starts with being a servant leader. I'm sure you are. That's really where my jam occurs. So making sure that your frontline colleagues have everything they need to do their job really, really well. On the culture side, we went to a conference about 3.5 years ago, 4 years ago, and David Friedman, who is a consultant on the East Coast, he wrote a book called Culture by Design. And what Culture by Design does is say, take your culture and then develop specific action behaviors that support your culture. We had the culture in place, but we really didn't have the behaviors behind it. So we had a group, the physicians, of course, were part of it, came up with 26 different behaviors, things like be curious, not judgmental. And that came out before Ted Lasso. Be present. How you do anything is how you do everything. Be fanatical about response time and on and on. And we put those up every week. There's 26 of them. So we put one up a week and then you flip it. So you're getting them twice a year. We lead off each of our meetings with what the culture, the fundamental, we call it, of the week is. All of our performance reviews all go back to supporting our culture. When we hire somebody, no matter who they are in the organization, their first day, their leader takes them out to lunch. And at that lunch, talks to them a little bit about the culture organization, what to expect and things like that. And the feedback we've gotten people with their 90-day reviews about taking people out to lunch on their first day has been probably one of the best things we've done. It really does show that you're part of something bigger than yourself. We want you to be part of this. We're going to support you through your journey and kind of see where you go.
Yeah. Yeah. I like that you brought up servant leadership. I actually had a high school football coach that preached servant leadership. And that's where I first heard about it. And it's always stuck with me. And so it's something I think about today too. If I'm not willing to do it, then why would I expect someone else to do it? And so just getting your hands dirty, so to speak, and doing the work and showing them that, you're part of the team too. I think that's huge. It speaks volumes.
I agree.
Yeah. Let's see here. How do you balance high quality patient care with the realities of running a business?
They go hand in hand. If you don't have high quality patient care, you're not going to have a business.
Sure.
It kind of works that way. The tough part in a day and age when healthcare is so consumer focused, and we preach this now. I preach it a lot to our folks. We talk to the docs about it. When someone has knee pain, they don't automatically go to their primary care doctor who sends them to us or sends them to physical therapy or does something like that. They go onto their cell phone. They look you up. They look at what your Google ratings are. They look at your vitals. They want to know that they can make an appointment online.
Yep.
They want to pay their bill online and schedule online. Basically, they want to do everything without talking to anybody. Right?
Yeah.
So we've really had to pivot a lot of what we've done to create digital pathways and create that ability for patients to get here.
Sure.
And I think when they go through that, when you walk into a nice steakhouse, you're going to pay a little bit more, right? But you don't walk into a nice steakhouse and they treat you like crap and the place looks like a dump and whatever. It's usually very
Right.
nice.
Right.
If you create that pathway, people are willing to invest in you. And that's what we want. And to create that pathway, you have to start when they're at home. Their first visit for you, for me, for anybody in healthcare occurs at home now. It doesn't occur here. You don't know if the first visit went well if they make an appointment. But you don't know how many of those people tried to do that first visit at home, didn't make an appointment, and you failed.
Yeah.
So we constantly look at how many people are hitting the schedule button on our website, who's interacting with us, because we want to make sure that we get a really high rate of return on those folks that are digitally starting their journey with us.
Yeah. How to balance the digital, like you said, a lot of people like to do, they don't want to talk to a person, but then, once they do get to the clinic, because like for us, for example, our EMR has the capabilities where we can put a kiosk up front and they can just check themselves in. They can pay their bill up there and they don't have to interact with anyone. I've purposely avoided that.
Correct.
Because I like that human interaction, and I think the patients value that. So how do you kind of balance that? Like once they're in the ecosystem, then
you absolutely have certain principles. That's been brought up before. Hey, we can put kiosk in and have them check in, and like, no. The most important person is that first person they deal with.
Yeah.
Which is your front desk person. I learned that. That's how you learn PT and carry it over. It's not that much different. You have to have a front office person that does a good job, right?
Right.
And then it's preaching throughout the organization every step of the way that you're really about this patient's experience with us. The one commonality, and my staff is probably tired of hearing me say this, but the one commonality of any patient that walks into our clinic, our buildings, walks into your building, is they're fearful of something. They're fearful of, am I ever going to get better? Am I going to go back to work? Do I have cancer? I mean, all those different things. I'm sure you've experienced where you're doing an evaluation of a patient and you said, oh, it's a psoas strain. You're like, oh, I thought I had MS.
Yeah.
In the back of your mind, like, what the? But they really thought they had that, right?
Yeah, for sure.
That's where you're really able to make a really lasting impression relationship with a patient, is when you can listen to them and calm them down and walk them through their journey. We get a lot of compliments on when our x-ray techs will get a patient from the waiting room and walk them back. And how many people comment on it was nice to have someone walk me back to where I needed to go and talk to me along the way because it made me feel better. Little things, they matter.
Yeah. Right. Yeah. There's so many patients and they come in here for the first time. They're so nervous and fearful. And, we kind of, when you've been doing it forever, you kind of forget hard. Like, it's just physical therapy to us, but it's not to them, and it's their first time experiencing whatever's going on, especially if they've had surgery and they don't know what the next 6 months are going to look like, or year, or whatever that is. And so,
right.
Exactly. So that's something we kind of pride ourselves in, especially the first visit, is just, taking 10 minutes at the end of the session, and we've got whiteboards in each of our offices. And so we write that whole process out. So, hey, this is what it's going to look like. This is what you've got going on. Mm-hmm. This is how it's all kind of plays in together. And this is our plan. This is how we're going to attack it.
It's a great idea.
I've had so many people just sit there and they're like, why hasn't anyone ever explained that to me before? You kind of look at them and you're like, I don't know. Like, someone should have been. You've been to 10 other people before me. So it's like, someone should have.
What a powerful connection, right?
For sure. Absolutely.
When they say that, man, I locked them in. This is
right.
great.
Right. You've created that bond with them. And so just building that trust and that rapport with patients is huge.
100%. No doubt. No doubt.
Yeah. Where do you think healthcare organizations get stuck in resisting change?
Wow. That's a human emotion, right? I think you can take healthcare out and put it anywhere else and say, how do you get stuck with change? Change is tough because it's security and control. And anytime you take that away from somebody, they're going to have problems with it.
Yeah, for sure.
I think that healthcare gets stuck because we have just so many silos. Not here so much, but when I was at the hospital system, you have departments and you have leaders of departments, and you got nurses and therapists and everything else. And it's really difficult to turn that boat around and have everybody facing the right direction. It's difficult here. Our guys they want to do things the way they want to do them. And that's fine. That's why you own a private practice, and we try to do that. But the times are changing to the point that you can say, it's fine if you want to continue to do it this way, but it's costing you X. We can do it this way, and it's going to not cost you as much, which that leftover margin, if you will, is the money we can reinvest in opening clinics and paying people more and doing things like that.
Sure.
So the change part that's been a fun little journey for us.
Yeah.
Since day one.
Now I'm curious, just because I'm a physical therapist, but as a physical therapist yourself, you ever get pushback when you're at the top here, but you've got a lot of very smart physicians, surgeons working underneath you? You ever get pushback, from those physicians? As
I try to
as a physical therapist, there, where they look at you and say, like, "Hey, you don't understand what's going on in the OR," or something, something like that.
well, and I think that the key part of that is never get yourself in that situation, right? And
Absolutely.
you got to really kind of pre-plan things out. We are a privately owned, physician-owned practice, so each physician's an owner in the practice. My job is to work with them to keep the practice going forward, and then making sure that we support the staff and keep people in the right direction, right? So trying to avoid that is the key. And luckily, up to this point, I have,
Sure.
because I'll lead with, look, I've been in the room, I've been behind the door, I've been in the room with that patient that just talks incessantly. I've been in that room with the patient that you just can't get a word out of, right?
Yeah.
I've been in the room with the parent that may not be the best parent to deal with
Yeah.
at the time. The difference is I was in the room for 40 minutes with them and you're in the room for 10 minutes with them.
Yeah.
But I've never been in an OR, right? So
Sure.
I do lead with that. They've earned the respect, and they've earned the well, respect's a good word, of having the last word. They own the place, right?
Sure.
But we're blessed with a great group of guys that when you present something, if it makes sense, they're going to go do it. And we have a very strong physician leader with myself, our board president, Nick Honkamp. And Nick and I
Yeah.
work very closely together. And there are times I tell him this is a doctor to doctor talk. That's probably what you're referencing, is when
Yeah.
maybe we had a problem in the OR, we had a problem
Sure.
somewhere else. I'll be there, but you got to lead the conversation. And he
Yeah.
gets it, and I get it. And then there's times like I got this one because it's something different.
Yeah.
So having that key, having a physician leader, and then having the administrator, which I hate that word, but the administrator portion of
Yeah.
things,
Yeah.
I think that really helps.
How do you think your healthcare experience has helped with your leadership position now?
It's hard to lead something you don't understand.
Yeah.
And understanding the whole, we call it the whole board. I tell my colleagues, look at the whole board. Don't look at this problem in just what the problem is. Look at how it affects all the other things, and maybe you can have an idea how it started and what the proper pathway is out of it. I think having all those years in the hospital and seeing how it runs, having years here and seeing how it runs, allows me to see the board a little bit better. And having that backdrop gives you a little better compass on how to solve things. I think that's where administrators get in trouble, is they never were in the room with the patient,
Sure.
and that respect is lost.
Yep.
And they're great administrators out there, don't get me wrong, but it's just different. And I think being able to work with the patient and deal with other providers, there's a certain amount of respect that goes with that.
Yeah. Yeah. I would agree totally. What do you think separates organizations that thrive from the ones that struggle?
Culture, 100%. I mean, it's a culture of what you have, and the culture is the hardest thing to define. You kind of know it when you see it. You can feel it. It's not a campaign of the month. One thing that, the organizations I've been with previous to this, you'd have 3 years were this, and the next 3 years were that, and the next 3, well, that's not culture, right? Being able to say, as David Friedman says, culture's a dictatorship. It starts at the top. You own your place.
Yeah.
It starts with you.
Sure.
You set the culture. So when you hire people, you're hiring people that fit that. And we tell our hiring folks, our HR folks, they have got to fit the culture first. We'll teach them how to do whatever, but they have to fit the culture part first.
Yeah.
And I think that's what separates high functioning organizations, because in that case, you don't have turnover. You have people that are invested, and you can really do some cool things when you have those two things together.
Yeah, I was listening to a podcast the other day. It was with Andy Frisella. He's the owner of First Form Supplements. They're in St. Louis. And he said the exact same thing that you did, where he'll teach skill later, but it's all about culture, and that's what he hires for now. And he's made the mistakes over the years where he hasn't done that, but he's learned the hard way that you've got to build that culture, and you've got to hire for that and train the skills on the back end.
That's the other part, is my gray hair tells you I've been doing this for a while, so I've made plenty of mistakes. And you're going to do that. Just learn from them.
Yeah.
Fail fast, then move on.
Absolutely. Absolutely. So do you think healthcare is moving in the right direction, or is it becoming more difficult to navigate?
I think on going back to the topic earlier, especially with this direct to employer part, I think that's the right direction.
Yeah.
Because in essence, it cuts out all these people that think they're part of the process, but they're really not. I think that for every action, there's an equal and opposite reaction. The action right now with America is that those that have employer-sponsored benefits are starting to pay attention because, one, they're too expensive, and two, they don't know how they work, but now they're trying to kind of understand that.
Sure.
We had these conversations 5-6 years ago, and the employees, they didn't care. I mean, you remember open enrollment's it's like, yeah, hit a button and move on. I got insurance, right?
Right.
Now it's a lot. They have to pay a lot more attention. So I think the literacy of our employee base our employer base throughout the country is improving. And when we understand how to use insurance, then we're going to make better decisions because we're going to know where to start. I go to my primary care doctor if I have an ear infection. I'm going to go to Brian if I've got back pain. And I go to DMOS if I blew my ACL out because I know I don't need therapy. Getting the right place at the right time really is going to help to decrease the cost of healthcare.
Yeah. Yeah. My wife's talked about this before too, and she does a lot of the back end billing, insurance verification. Our friend does that here as well. But especially this year, it seems like benefits change so much, and none for the better, it doesn't seem like. And
no, you guys, you're small, so I imagine you're through a fully insured plan, fully funded plan, something of that nature.
Yeah.
When you have a fully funded plan, the only levers that an employer can twist to keep the premium cost down is basically deductibles and copays.
Yeah.
So you've seen people have deductibles at $2,000, now have deductibles at $5,000. Well, that's the employer saying, well, I have to stay with this fully funded plan and then crank the deductible up. But what happens after a while, to your point, is deductible gets so high, the employee's like, what am I doing?
Yeah.
And the employer's like, what do I do? And getting the right broker is important. But if you have the right broker that says, hey, you should go self-funded, then you can direct your benefits. You can choose your network. You can choose your pharmacy benefit plan. You can choose where people go. You have a big opportunity to control the spend in that point.
Yeah.
I know I got a little bit technical and in depth, but that's really where we're going. When more folks go to self-insured plans and they control their benefit spend, you're going to see lower deductibles because that's what's going to happen. You're going to control them and keep them lower.
Yeah. Absolutely. I think I know what you'll say to this because we've kind of talked about it, but where do you think orthopedic care looks like in 10 years from now?
A lot of AI in the support services. I think that the phone centers, that a lot of our billing will have that. I don't think we'll necessarily decrease in the number of employees we have, but we won't increase because you still need people. No matter what AI does, you still need people. I think we're going to have a lot of that in the back end. I think that diagnostically, things are going to improve. I mean, who would have thought 10 years ago that you'd have a total knee in a surgery center and leave the same day? And we did 1,000 of them last year. We'll probably do 2,000 this year. So who knows what's going to happen beyond that?
Yeah, for sure. Is AI moving into the AI? I would imagine there's some resistance to that, but
there's a lot of resistance to that. Yeah. We hear about robotics all the time, and robotics is a fancy navigation system. The literature is about 50-50 on whether it really makes a difference or not. Our guys do both. We don't want them dependent upon robots because what if the robot breaks? So they do a little bit of both. But there are definitely complex cases where robots are helpful. People have extrapolated that out to, well, why can't the surgeon just sit in a control center and just move things around? And that's a little scary to me right now. But
are we flying a drone into the OR? What are we doing? Yeah. What trends in healthcare excite you?
You know what really excited me was, and it gets carried on to today, pre-Obamacare, healthcare is very siloed. Physicians were in one place, nurses were in one place, therapists were in one place, everybody's here. Physicians didn't talk to therapists. Therapists would give them information. The physician is like, you bet, whatever.
Yeah.
After Obamacare, it really tore those down and forced everybody to work together because generally you were getting a risk-based type of payment system where you had to have everybody on the same page. And tearing those down has been so great for healthcare. You spoke with Jason Sullivan a couple weeks ago. Dr. Sullivan listens to everybody, does a great job of, with his difficult cases, talking to the therapist, talking to the patient, keeping in track, because it's a team effort to get them better. And that's what excites me about healthcare is the continued collaboration amongst every level in the system.
Yeah. That was one of my, prior to this, I was right out of PT school. I joined the Navy as a physical therapist. Did that for 5 years. Yeah. Thank you. And that was really one of my favorite aspects of it is, I was in Bremerton for 2 years. I was in Okinawa for 3 years, but both places I had orthopedics right next door to me. Family practice was a couple more doors down. Radiology was right across the hall. And Okinawa neurosurgery was right above us. there was, you talk about collaboration, it was all right
Yeah.
there. And I could walk over to orthopedics at any time and say, hey, I've got this going on. Like, what do you think of this? Or, we had direct access there as well. So you get a patient that walks in with this injury and, it's like, hey, you need more than me. I can
Uh-huh.
I can order an MRI, but why don't I walk next door and talk to the surgeon and see if he'll take a look at you real quick? And so you can walk over and chat. There was many times I'd walk across the hall to radiology and say, hey, I know you read this image as this. Can you just show me, like, what are you seeing on there? I'm trying to look at
Uh-huh.
it on my screen and I'm not trained as you are. So what do you see? And so many opportunities like that. We'd have the neurosurgeon come down and go through some case studies for us. And so it's just a huge collaborative environment. And I learned so much from that time period, just from asking questions. And honestly, there was a lot of times too, I'd walk next door and I'd sit down on the couch as the ortho surgeons just chatted away. Or maybe they're talking about cases and they're reviewing imaging and
Uh-huh.
discussing indications and things like that. But I would just sit there kind of like a fly on the wall and soak it all in. And it was awesome. I loved it.
It is.
So,
That's one of the factors behind us having an end-to-end MSK offering is that, you walk into one of our urgent injury clinics and our PACs, you can walk downstairs, talk to the physician, walk over to the MRI, talk to the MRI, and you're getting all that stuff done in a relatively quick period of time. But
yeah,
there's a great communication between everybody in
yeah,
the pathway.
right.
Um, and that's really awesome.
Yeah,
That's something that I'm really happy that we put into place and has provided great bilateral experiences for the patient, of course, that's what you're
yeah,
focused on, but also for the X-ray tech or the MRI tech or the PA or the PT or whomever, because they have that interaction and feel like they're part of something bigger than themselves or part of the
yeah,
team.
right. Absolutely. And then the patient benefits from that.
Oh yeah.
Everyone's on the same page, including the patient. They know exactly what to expect. There's no anxiety because they don't know where they're going from there or what's going to happen next. Everyone's on
Remember that
board. And
fearful comment?
exactly.
You assuaged their fear and you made a lasting impression, really helped somebody out.
Yeah, absolutely. Absolutely. Let's see here. What's one thing that patients should demand more of?
Transparency. Patients should know where their dollars are going.
Yeah.
They should know how much it costs and why it costs that much. That's the trouble, is they don't understand why it costs that much. They see that EOB and they're like, really? It cost me $200 for this? And then you have to go through, well, this is how you get paid. You set the
Yeah.
price here. We don't get paid 200, we get paid X off of that.
Right.
But
Yeah.
transparency, because one of the biggest problems we have right now in healthcare is since the pandemic, trust is absolutely in the garbage for healthcare providers. Probably
Sure.
not PTs as much because we were never looked at as, what's the word I'm looking for? We were never looked at as a frontline part of PT, but
Right. Right.
nurses, physicians, hospitals, there's just no trust.
Yeah.
And helping to build that trust going forward is really critical to being successful. And you build trust by having a system that works really well, like what you're explaining with the whiteboards. People
Yeah.
walk out of there and they trust you because it's like, that was a great experience. They knew exactly what they were doing.
Right.
Even if you didn't, because sometimes the PT, you're like, I don't know what's going on here, but we're going to get you better,
Sure.
right?
Yeah. Yeah.
You're able to get that trust back, and all those little interactions will hopefully build it back to where we are now. But price transparency, they see their EOBs from a hospital and they have no idea why they pay what they pay and where
Yeah.
dollars are going. And you have a transparent system that can really help out.
Yeah. Yeah. Dr. Vanderveer, he hit on transparency quite a bit as well. It's huge. I had a patient, this is a couple of years ago. She brought her EOB in here and she's kind of shaking at me and she blamed me she goes, this is why my insurance rates are so high. You're charging so much. And it's like, well, I did the same thing. I went and sat down right beside her and let's talk through this and let me explain to you why it looks like you're getting charged so much. But if you look at this line item over here, I'm not getting paid what that is. And
what that says.
Yeah, that's a whole other topic too, that old insurance game. But
It is, but it's funny how automatically the consumer goes to us as providers, PTs, doctors, whatever, as being the prime cause of why healthcare is going up.
Right.
I would challenge you to go into any large city in the United States and find that one of the top 3 largest buildings downtown isn't an insurance building.
Yeah.
There's a reason for that. We have a huge one downtown right across from the library.
Yeah.
There's a reason for that. All really those organizations do is they just adjudicate claims. They're a claims processor.
Yeah.
Oh, they do, but they've added all these stacks of administrative burden on the top that your premiums go up every year. So it's really not us.
Right.
And yeah, and we need to be paid more each year, but do you really pay us that much more every year?
Yeah.
Not so much.
Right. Right. Yeah. Medicare is a perfect example of that as well.
Oh boy. Yeah. Yeah.
Yeah.
There's unfortunately some orthopedic groups. We're part of a large group called the Orthopedic Forum. That's made up of private orthopedic groups all across the country. I think there's 150 in it right now. Great group because we can interact and a little bit cathartic, a little bit um, uh, preaching a little bit on the virtues of what orthopedic practice looks like. And recently, there's been a push to stop seeing Medicare patients because some groups, especially on the East Coast, some groups lose money.
Yeah.
We won't stop. I don't want anybody to listen to this and think DMOS is going to stop seeing Medicare patients. We're not. That's one of they're our biggest payer mix. But the government has to understand that you can't run a business on these revenues that these reimbursements that don't keep up with inflation.
Yeah. Yeah. That's, I like that you brought that up, the inflation, because there's, this year reimbursement went up for physical therapy until you look at inflation and it actually went down.
Right. And look at the last 10 years. How much has it gone up?
Yeah. Yeah. People are all excited at first. Oh, we're going to get paid more. And it's like, well, not really. Inflation went up so high that it doesn't matter.
Yeah. You kind of played for the tie on that one.
Yeah.
In the state of Iowa, here's a tough one. In the state of Iowa, we have worked tirelessly with HHS to try to get Medicaid rates to move for musculoskeletal CPT codes. The state of Iowa hasn't changed the reimbursement on their musculoskeletal CPT code since 2012. We're getting paid Medicaid rates at 2012 rates.
Wow.
Who does that?
Yeah. Yeah. Who can keep up with that?
Can't.
Yeah. Wow. That's I don't even know what to say to that. Took the words right out of me. Well, Rich, I don't want to keep you all day. I respect your time and I appreciate you for being here. Is there anything we haven't talked about that you'd like people to know or you'd like to talk about here?
I'm a grandfather. How about that?
Hey, congrats. Yeah. Yeah, that's fun.
Yeah. 2 times actually, coming up here pretty quick.
Yeah.
No, I mean, we're blessed to be part of the Des Moines community. We've been around since 1955. Yeah. That says a lot. We've got a great group of surgeons that we work with, blessed in that manner as well. So we're just going to keep on doing our thing and chugging and working down the road to really try to bend the cost of healthcare.
Yeah.
See where that goes.
Yeah. What's next for DMOS?
Well, open that Norwalk clinic up and see what happens with that. And then look at what other locations potentially would be on our radar. Again, healthcare is consumeristic. You can't drive 3 miles and not see a Starbucks because people don't want to drive, right? So having access points throughout the town is really important.
Yeah.
Thus far, like I said, we put Urbandale up. It's been doing really well. We anticipate similar out of Norwalk when we get that going. And then look at the only 2 left would be Altoona and Waukee. We've got a place in Ankeny. So
yeah.
See where we go next.
How big of a focus is access to care for you?
One.
Yeah.
That's part of our digital pathway. Remember that first appointment occurring at home? That's your appointment 1. Making sure people can get online, go to DMOS.com. Anything they need is on DMOS.com. They can do a virtual visit. They can schedule an appointment. They can pay a bill. They can do all those different things. And then being able to be geographically close to where the physical therapy is or where the clinic is or where your urgent injury is. Our urgent injury clinics are they're our fastest growing of all of our ancilleries. Because it's a walk-in situation. These people walk in, they get taken care of, and they leave, and they're like, my goodness, I went to the hospital, and it was a 5-hour wait.
Yeah.
Hour and a half wait.
Yeah.
At considerably less cost.
Yeah, that's huge.
Yeah.
Awesome. This has been absolutely great. Thank you so much for being here. Appreciate you.
Thank you.
So